One condition is responsible for more unexplained fatigue, joint pain, and organ damage than almost anything else in modern medicine, and most people have never heard its name. It's estimated to affect several million people, the vast majority of them women. It hides behind vague complaints for years. It's rarely screened for at your annual physical. It was barely mentioned in most doctors' training. And while it can't be cured, it can be caught early, slowed, and managed well enough that most of its worst complications never happen. It's called Sjogren's disease. By the end of this video, you will understand it better than most people who've lived with it for years without a name for what's happening to them. This is the complete guide. What Sjogren's disease is, how it develops, what it does to organs beyond the obvious ones, why the system misses it, and how it's managed once it's found. You've heard the phrase dry eyes or dry mouth tossed around like a minor inconvenience. But nobody's ever explained what's actually happening inside the immune system, what it's doing to the rest of the body over years, or what the research says about catching it early. That's the gap between hearing a symptom and understanding a disease. And this is where people, especially women, lose years they did not have to lose. I'm not a physician. I'm a researcher. I spend my time reading the primary literature, the rheumatology journals, the epidemiological studies, the diagnostic delay data, and translating it into something a person without a medical degree can actually use. I got interested in this condition because of how consistently the research describes the same pattern. Symptoms dismissed for years, a diagnostic odyssey that spans multiple specialists, and a disease that, once named, often turns out to explain years of complaints that never quite added up. Everything in this video is drawn from published research and clinical guidelines. It is not medical advice, and it is not a substitute for evaluation by a qualified clinician, a rheumatologist, in most cases. Think of this as the research briefing you'd want before that appointment, not a replacement for it. 6 sections. What Sjogren's disease actually is, the history of how it was discovered and defined, how it develops undetected for years, what it does across nearly every organ system, why the diagnostic system consistently misses it, and what the research says about managing it well once it's found. What Sjogren's disease actually is. Sjogren's is an autoimmune disease. In autoimmune conditions, the immune system, which is built to identify and attack foreign invaders like viruses and bacteria, loses the ability to distinguish self from non-self, and begins attacking the body's own tissue. In Sjogren's, the primary targets are the exocrine glands, the glands responsible for producing moisture throughout the body. The two most affected are the salivary glands, which produce saliva, and the lacrimal glands, which produce tears. Research using biopsy studies has shown that in affected glands, immune cells, primarily lymphocytes, infiltrate the glandular tissue and form clusters of chronic inflammation. Over time, this infiltration damages the gland's functional tissue and reduces its ability to secrete fluid. That's the biological basis for the 2 hallmark symptoms: dry eyes, medically termed keratoconjunctivitis sicca, and dry mouth, xerostomia. But researchers have increasingly come to understand that this is not simply a dry gland disease. The same underlying immune dysfunction, B-cell hyperactivity, autoantibody production, and chronic inflammatory signaling, doesn't reliably stay contained to the exocrine glands. In a meaningful percentage of patients, it extends outward to affect joints, skin, lungs, kidneys, peripheral nerves, blood vessels, and in rare but documented cases, the lymphatic system itself. This distinction matters enormously, and it's one that research has clarified more precisely over the last 2 decades. Sjogren's is increasingly described as a systemic autoimmune disease with glandular and extraglandular manifestations, not a dry eye and dry mouth syndrome with occasional complications. The glandular symptoms are simply the most visible and most commonly reported piece of a broader disease process. There's also an important distinction researchers draw between primary and secondary Sjogren's. Primary Sjogren's occurs on its own. Secondary Sjogren's occurs alongside another autoimmune condition, most commonly rheumatoid arthritis or lupus. Both forms share the same core glandular and systemic features, though the presence of a second autoimmune disease can complicate the clinical picture and, ironically, sometimes delay recognition of Sjogren specifically, because clinicians attribute new symptoms to the already known condition. Epidemiologically, published prevalence estimates vary depending on the population studied and the diagnostic criteria used, but Sjogren's is consistently described in the literature as one of the more common systemic autoimmune diseases, second only to rheumatoid arthritis in many estimates. The sex disparity is one of the most striking and consistent findings across studies. Roughly 9 out of 10 diagnosed patients are women, and onset most commonly occurs in midlife, though it can appear at almost any age, including in children in rare cases. It's worth pausing on why the female predominance matters practically, not just statistically. Research on autoimmune disease more broadly has repeatedly found that women's symptoms are more likely to be attributed to stress, hormonal changes, or psychological causes before a physical disease process is investigated. For a condition that already presents with vague, easily dismissed symptoms like fatigue and dryness, this compounding effect appears repeatedly in patient-reported diagnostic delay research. It's a bit like this. Imagine a security system with sensors placed only at the front door of a house, while the actual intrusion is happening slowly, room by room, through the back. The alarm was never built to detect what's actually occurring. That's a reasonable way to think about how the standard primary care visit is structured relative to a disease like this. It's simply not built with the right sensors in the right places. This has likely been building for longer than most patients realize, while routine blood work kept coming back reassuring. But to understand why that happens, it helps to look at how the disease actually progresses before diagnosis. A brief history: how a syndrome became recognized as a disease. Understanding why Sjogren's is so frequently missed benefits from understanding its history, because the history explains a lot about the diagnostic infrastructure, or lack of it, that exists today. The condition is named after Henrik Sjogren, a Swedish ophthalmologist who, in the 1930s, published detailed clinical observations of patients, most of them women with rheumatoid arthritis, who also had severe dry eyes and dry mouth. His work described what he called keratoconjunctivitis sicca in the context of a broader systemic illness, but it took decades for the condition to be widely recognized as a distinct disease entity rather than an unusual complication of rheumatoid arthritis. For much of the 20th century, Sjogren's was frequently classified as a secondary phenomenon, something that happened to people who already had rheumatoid arthritis or lupus, rather than being investigated as its own primary disease. It wasn't until later research clarified that Sjogren's frequently occurs entirely on its own, without any other autoimmune diagnosis present, that primary Sjogren's became a widely used and studied category. Diagnostic classification criteria have also evolved substantially over time, and this evolution is still ongoing. Multiple versions of formal classification criteria have been published and revised over the decades: European criteria, American European Consensus criteria, and more recently, Joint American College of Rheumatology and European League Against Rheumatism criteria. Each revision has attempted to balance sensitivity, catching real cases, against specificity, avoiding false positives, and each has shifted how heavily different tests are weighted: antibody testing, objective dryness testing, and salivary gland biopsy findings among them. This matters practically because it means the gold standard for diagnosis has not been static. A patient evaluated in one decade under one set of criteria might have been classified differently than a patient with an identical presentation evaluated under revised criteria in a later decade. Research on diagnostic delay has to be interpreted with this in mind. Some of the historical difficulty in diagnosing Sjogren's reflects genuinely difficult biology, and some of it reflects a diagnostic framework that itself was still being refined. How Sjogren's disease develops undetected. Sjogren's does not typically announce itself with a single dramatic event. Research describes it as an insidious, slowly progressive process, and this is one of the most consistent findings across diagnostic delay studies. The immune infiltration of the salivary and lacrimal glands appears to begin well before symptoms become severe enough to prompt a doctor's visit. Early on, glandular function may decline gradually enough that patients compensate without realizing it, drinking more water, using over-the-counter eye drops occasionally, attributing dry mouth to caffeine or aging. Because these are also extremely common complaints in the general population for entirely unrelated reasons, they rarely trigger suspicion of an underlying systemic disease on their own. Diagnostic delay research is one of the most consistently cited data points in the Sjogren's literature, and for good reason. It captures the real-world cost of how easily this disease is missed. Multiple published studies, across different countries and healthcare systems, have found that the average time from symptom onset to diagnosis commonly falls somewhere in the range of several years. Figures of roughly 3 to 6 years appear repeatedly, though some patient-reported surveys describe delays stretching considerably longer. This is not a fringe finding, it's one of the more replicated observations in the field. During that window, patients frequently report seeing multiple different specialists before receiving a unifying diagnosis: an ophthalmologist for eye dryness, a dentist for cavities and mouth discomfort, a rheumatologist or general practitioner for joint pain, sometimes a neurologist for numbness or tingling, sometimes a pulmonologist for a chronic dry cough. Each specialist, working within their own domain, may treat the symptom presented to them without ever connecting it to symptoms being independently evaluated elsewhere. It's a bit like this. Picture a slow leak in a pipe that runs behind a wall, feeding into several different rooms of a house. In the kitchen, someone notices a faint smell. In the bedroom, someone notices a small stain on the ceiling. In the bathroom, water pressure seems slightly off. Each room's occupant calls a different specialist, one to check the smell, one to check the stain, one to check the pressure, and each specialist patches their own local problem without ever tracing the pipe back to its source. Meanwhile, the leak has been running the entire time. This pattern, chasing individual symptoms without a unifying framework, appears repeatedly in patient-reported experiences documented in qualitative research on the diagnostic odyssey many autoimmune patients describe. Fatigue deserves particular mention here, because it's one of the most commonly reported symptoms in Sjogren's and one of the least specific. Research has found that fatigue in Sjogren's is often disproportionate to what would be expected from the degree of dryness alone, suggesting it reflects the broader systemic inflammatory process rather than simply the discomfort of dry eyes and mouth. But because fatigue is such a common complaint across dozens of unrelated conditions, and because it's notoriously difficult to quantify objectively, it's rarely, on its own, enough to prompt autoimmune testing. None of this means the disease is undetectable. It means the standard structure of a routine primary care visit, a brief appointment addressing whatever single complaint is raised that day, is poorly matched to a disease that presents as a slow accumulation of seemingly unrelated symptoms across multiple body systems over years. What Sjogren's disease does across the body. Research on Sjogren's describes its effects in two broad categories: glandular manifestations, which are the hallmark and most commonly recognized features, and extraglandular, or systemic, manifestations, which occur in a meaningful subset of patients and are responsible for most of the disease's more serious long-term risks. The eyes. Reduced tear production leads to keratoconjunctivitis sicca, a chronic dryness of the eye surface. Beyond simple discomfort, research has documented that untreated or poorly managed chronic dry eye can damage the corneal surface over time, increase susceptibility to eye infections, and in more severe cases, contribute to vision complications. Patients frequently describe a gritty or sandy sensation, light sensitivity, and blurred vision that fluctuates throughout the day. The mouth. Reduced saliva production has consequences that go well beyond discomfort while eating. Saliva plays a protective role for oral tissue and teeth. It helps neutralize acid, clears food debris, and has antimicrobial properties. Research consistently documents a sharply elevated rate of dental cavities and oral infections, including fungal infections like oral candidiasis, in patients with significant salivary gland dysfunction. Difficulty swallowing dry foods, altered taste, and a persistently sore or cracked oral mucosa are also commonly reported. The joints. A substantial proportion of Sjogren's patients report inflammatory joint pain, frequently symmetrical and affecting the small joints of the hands, in a pattern that can closely resemble early rheumatoid arthritis. Unlike the joint damage seen in rheumatoid arthritis, joint involvement in Sjogren's is typically non-erosive, meaning it doesn't usually cause the same permanent structural joint damage, but it can still be a significant source of chronic pain and reduced function. The skin. Dry skin, xerosis, is common. Some patients also develop a distinctive rash related to small blood vessel inflammation, called cutaneous vasculitis, which can present as small red or purple spots, most often on the lower legs. Raynaud's phenomenon, where fingers or toes turn white or blue in response to cold or stress due to blood vessel spasm, is also reported at elevated rates in Sjogren's patients compared with the general population. The lungs. In a subset of patients, chronic dryness extends to the airways, contributing to a persistent dry cough. More significantly, research has documented interstitial lung disease in Sjogren's, a condition involving inflammation and potential scarring of lung tissue, occurring in a meaningful minority of patients, with estimates varying across studies depending on how carefully lung imaging is pursued. This is one of the extraglandular manifestations that researchers emphasize is likely underdiagnosed, because it requires specific imaging that isn't part of a routine workup unless respiratory symptoms prompt it. The kidneys. A specific kidney complication called renal tubular acidosis has been documented in Sjogren's patients. This condition disrupts the kidney's ability to properly regulate acid-base balance in the blood, and in some cases can also contribute to electrolyte imbalances or kidney stone formation. Kidney involvement is generally considered less common than glandular or joint symptoms, but is clinically significant when present, because it's rarely symptomatic in its early stages and is typically caught only through targeted blood and urine testing. The nervous system. Peripheral neuropathy, numbness, tingling, burning sensations, typically in the hands and feet, has been documented in Sjogren's patients at rates that vary across studies but are consistently higher than in the general population. Some research also describes small fiber neuropathy specifically, which affects the smallest sensory nerve fibers and can be more difficult to detect on standard nerve conduction testing, potentially contributing to further underdiagnosis of this particular complication. The lymphatic system. This is one of the most clinically significant extraglandular risks associated with Sjogren's. Multiple studies have found that patients with Sjogren's carry a meaningfully elevated lifetime risk of lymphoma compared with the general population, most commonly a subtype called mucosa-associated lymphoid tissue, MALT, lymphoma, frequently arising within the salivary glands themselves, the same tissue already affected by the chronic autoimmune inflammation. While lymphoma remains a relatively uncommon outcome in absolute terms, researchers consistently flag it as a key reason ongoing monitoring matters even after a Sjogren's diagnosis is established and glandular symptoms are being managed. Reproductive and other systems. Vaginal dryness is a commonly reported symptom with meaningful effects on quality of life and intimacy, and research has found it's often underdiscussed in clinical visits relative to how frequently it's reported by patients when specifically asked. Some research has also explored associations between Sjogren's and thyroid autoimmune disease, given that autoimmune conditions frequently cluster together in the same individuals. Patients with one autoimmune disease have an elevated likelihood of developing a second. Framed together, this is not 7 or 8 unrelated problems that happen to occur in the same person. It's the documented range of one underlying autoimmune process, expressing itself differently depending on which tissues are most affected in a given individual. Research strongly supports the idea that coordinated, multidisciplinary care, rather than each specialist independently managing their symptom, produces better outcomes and catches complications earlier. Why the diagnostic system consistently misses this? None of this reflects individual clinicians being careless. The research points to several structural reasons why Sjogren's is disproportionately difficult to diagnose within a typical healthcare system. There is no single definitive test. Diagnosis relies on a combination of findings rather than one decisive lab value. The most commonly used tools in the research and clinical literature include blood testing for specific autoantibodies, most notably anti-Rho SSA and anti-La SSB, objective measurement of tear production, commonly through a Shummer's test, where a small strip of paper is placed at the edge of the eyelid to measure moisture over a set time, and a minor salivary gland biopsy, typically taken from the inner lower lip, which allows direct microscopic examination of glandular tissue for the characteristic lymphocytic infiltration. Formal classification criteria combine several of these elements, along with symptom questionnaires, into a composite score. There is no equivalent to a single blood glucose reading that definitively confirms or rules out the disease. A meaningful share of patients test antibody negative. Published estimates vary, but a substantial minority of patients who meet clinical criteria for Sjogren's, commonly cited at somewhere around a quarter to a third or more, depending on the study population, do not test positive for the anti-Rho SSA or anti-La SSB antibodies most commonly used in initial screening. Research suggests seronegative patients may face even longer diagnostic delays, because negative antibody results are sometimes treated as ruling out the disease, when the research does not support antibody status alone as sufficient to exclude it. Symptoms overlap heavily with common, nonspecific complaints. Fatigue, joint aches, and just feeling dry are among the most common complaints in general medicine, associated with dozens of far more common and far less serious causes. Research on clinical decision-making has found that nonspecific symptom clusters are less likely to trigger specialist referral or autoimmune-specific testing than a single, dramatic symptom would. Standard blood work doesn't include Sjogren-specific testing by default. A routine annual physical typically does not include anti-Ro SSA or anti-La SSB antibody testing, a Sjogren's test, or any structured dryness questionnaire unless a patient specifically raises symptoms that prompt a clinician to consider it. Unlike, say, cholesterol panels, which are part of near-universal routine screening in adults, Sjogren-specific testing is almost always reactive rather than proactive. The classification criteria themselves are relatively recently standardized and continue to evolve. As covered earlier, the diagnostic framework used today reflects decades of revision, and clinical familiarity with the most current criteria varies significantly depending on a clinician's specialty and how recently they trained. General practitioners, who are typically the first point of contact for the vague early symptoms of Sjogren's, are not always the clinicians most current on rheumatology-specific classification criteria, which is part of why referral to rheumatology, when appropriate, matters so much. If you're evaluating your own history against this research, a few questions are worth having answered. Has anyone specifically and directly asked whether your mouth or eyes feel persistently dry, not just occasionally, but as an ongoing daily experience? Has a clinician ever ordered anti-Ro SSA or anti-La SSB antibody testing specifically? Has anyone measured your tear production objectively, through a Sjogren's test, or discussed a minor salivary gland biopsy as a diagnostic option? Have you been told your labs are normal while still living with a combination of fatigue, joint pain, and dryness that affects your daily functioning? If the honest answers are no, 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 and yes, the research would suggest this is a fairly common gap in how the system is currently structured to look for this disease, not evidence that nothing is actually wrong. What the research says about managing Sjogren's well. Here is where honesty matters most, and where this differs meaningfully from conditions that are described as fully reversible through lifestyle change alone. Sjogren's is a chronic autoimmune disease. Based on current research, there is no cure, and it cannot currently be reversed through diet or lifestyle modification the way some metabolic conditions can be. What the research does support, consistently, is that earlier diagnosis and structured, ongoing management meaningfully improve quality of life and reduce the risk of serious downstream complications. Diagnosis itself changes outcomes. This sounds almost too simple to state, but the research supports it directly. Patients who receive an accurate, timely diagnosis are positioned to access appropriate treatment and monitoring far earlier than those who spend years being treated symptom by symptom without a unifying framework. A name for the condition is not just psychologically validating, it changes the entire subsequent care pathway. Glandular symptom management is the most well-established piece of Sjogren's treatment. For dry eyes, this typically includes artificial tears used regularly, not just when symptoms are severe, and in more significant cases, prescription anti-inflammatory eye drops or punctal plugs, which are small devices inserted into the tear ducts to help retain existing moisture on the eye's surface longer. For dry mouth, treatment options include saliva substitutes, and in some cases prescription medications like pilocarpine or cevimeline, which stimulate the remaining functional salivary gland tissue to produce more saliva. Rigorous dental care, more frequent cleanings, fluoride treatments, and prompt attention to any cavities, is specifically recommended in the research given the sharply elevated cavity risk associated with reduced saliva. Systemic and more severe disease management typically involves a rheumatologist and may include hydroxychloroquine, a medication also used in lupus and rheumatoid arthritis, which research has associated with modest improvement in some systemic symptoms including joint pain and fatigue in a subset of patients, though findings across studies are mixed enough that clinicians often individualize this decision. For more significant organ involvement, meaningful lung, kidney, nerve, or blood vessel disease, immunosuppressive medications may be used, chosen, and monitored specifically based on which organ systems are affected and how severely. Ongoing monitoring is emphasized throughout the research as a distinct and separate priority from symptom treatment, particularly because of the elevated lymphoma risk discussed earlier. This generally means regular follow-up with a rheumatologist, periodic reassessment of salivary and lacrimal gland function, and clinical attention to specific warning signs, such as persistent swelling of the salivary glands, especially if it's new, one-sided, or accompanied by a firm, non-tender lump, which can prompt further evaluation for lymphoma specifically. Lifestyle factors, while not curative, do appear repeatedly in the research and in clinical guidelines as meaningful supportive measures. These include using a humidifier, particularly in dry climates or during winter heating season, avoiding medications that worsen dryness where alternatives exist, since certain antihistamines, decongestants, and antidepressants are known to reduce saliva and tear production further, staying well hydrated, protecting the eyes from wind and dry air with wraparound sunglasses when outdoors, and maintaining consistent, proactive dental hygiene rather than reactive care after problems develop. It's worth returning to the pipe analogy here, adjusted for what management actually looks like. A chronic, slow leak behind a wall isn't something you fix once and never think about again. It requires ongoing maintenance, checking the same access points regularly, catching new drips before they spread, and preventing small, contained problems from becoming structural ones. Managing Sjogren's, based on the research, works the same way, not a single intervention, but a sustained, coordinated process of monitoring and targeted treatment across whichever systems are affected. So what does the research suggest you can actually do with this information? Track your own symptoms with dates and specifics: dryness, fatigue, joint pain, anything unusual, rather than relying on memory at a rushed appointment. Diagnostic delay research repeatedly finds that vague, undocumented symptom reporting is part of what makes these patterns hard for clinicians to piece together in a short visit. Ask directly and specifically, based on my symptoms, should we test for Sjogren-specific antibodies, or would a rheumatology referral make sense? Specific, named requests are more likely to prompt specific, named testing than a general description of feeling unwell. If antibody testing comes back negative but symptoms persist, don't treat that as a closed door. The research is clear that a meaningful share of confirmed Sjogren's patients are seronegative, and further evaluation, including discussion of a Schumann's test or salivary gland biopsy, may still be warranted. Protect your teeth and eyes proactively if you're experiencing chronic dryness, even before any formal diagnosis. The downstream damage from untreated dryness, cavities, oral infections, corneal irritation, is well documented and, unlike the autoimmune process itself, is genuinely preventable with consistent care. Bring one clear, specific question to your next appointment. Could my dryness, fatigue, and joint pain be connected to one underlying condition, rather than being three separate issues? Naming the possibility of a unifying diagnosis, out loud, changes how a clinician approaches the visit. Every symptom you document is data a future clinician can actually use. Every specific, named question is a chance to shortcut a diagnostic delay that the research shows commonly stretches into years. Every proactive step to protect your teeth and eyes reduces damage that compounds the longer it goes unaddressed. None of these individual actions cure the underlying disease, but together, based on what the research shows, they meaningfully shorten the path to diagnosis and reduce the risk of preventable complications along the way. Sjogren's disease affects several million people, the overwhelming majority of them women. It hides behind symptoms, dryness, fatigue, joint pain, that are individually common and easy to dismiss. It can affect organs well beyond the eyes and mouth, including the lungs, kidneys, nerves, and in a meaningful subset of patients, the lymphatic system. It is consistently and repeatedly missed or delayed by a diagnostic system that isn't structured to look for a slow, multi-system process using a single lab value. It cannot currently be reversed, but the research is clear that it can be diagnosed earlier and managed well, and that difference has a measurable effect on quality of life and long-term outcomes.